Hello and welcome to Unit 6 or Week 6 of our course. We are continuing with anatomy and physiology this week, specifically looking at the urinary system, reproductive system, endocrine system, and nervous system. In the nervous system, we'll also talk a little bit about the sensory system as well as some mental health things. You're going to want to make sure that you are looking at NHA Module 2 in the study guide, as well as your medical assisting basics textbook, because I am only going to hit the high points, again, covering the basics of these. These body systems can obviously go a lot more in depth, but we're just hitting the high points. Even this presentation won't have everything in it, so be sure that you're also looking at your textbook and that NHA module for everything you need to know for the exam. Here's your slide on key medical terminology as we are continuing to go through our anatomy and physiology chapters. You need to be more familiar with your medical terminology. This is why we start the program going through medical terminology, so that way when we get to this point, you're already familiar with a good bit of it. We'll cover some of these terms as we go through in this presentation, but if I don't get to all of them, these are still some terms that you need to know for testing purposes. Okay, so let's start with the urinary system, sometimes called the genitourinary system. I like that they mention it works sort of like a water filtration plant. That is a good way to look at that. It does filter your blood for both fluid and electrolyte balance. And this is really important for homeostasis. And we learned last week that homeostasis means that all the body systems are working together as they should. So everything is functioning as it should. The anatomy of the urinary system is only has 4 parts. That's the kidneys, which there are 2 of those. Ureters, again, 2 of those. There's 1 bladder and 1 urethra. Oftentimes students get ureters and urethra mixed up, so be sure that you're aware of the difference between the 2, which we're going to cover on the next slide. And then the physiology of what the urinary system does, we're going to go through on another slide as well, mainly filtering the blood. That is the key function of the urinary system. And then this slide also has some diagnostic tests and procedures related to the urinary system. For instance, a urinalysis, which when we get to our phlebotomy and point of care testing unit, we will talk a lot about urinalysis and what you're looking for in that. And then some lab work like a BUN, which is a blood urea nitrogen, a creatinine. All of these are checking for kidney function tests, cystoscopy, looking at the bladder, and catheterization. So those are some more terms or some tests that you're going to want to be familiar with. All right, so the anatomy of the urinary system. There are 4 parts. You have the kidneys. You have 2 of those, and they are typically what we call, we say right and left flank, usually more towards the back of your body or posterior. They are bean-shaped organs, and their primary job is to filter blood, remove the waste, and they make urine. These kidneys are crucial for homeostasis. And then you have 2 ureters that come down from the kidneys to the bladder, and they are tubes that transport the urine that has been made to the bladder. You have 1 urinary bladder, which is essentially just storage for urine until it's ready to be released. And then there is a urethra that connects the bladder to the outside of your body for elimination of that urine. Depending on if you're male or female, how long that urethra is. Typically in a female, it tends to be shorter than in a male. In a female, it tends to be about 1 to 2 inches, whereas in a male, it's about 6 to 8 inches. So if you'd ever wondered why females tend to be more prone to urinary tract infections, it's because of or oftentimes it's because of the length of the urethra. That bacteria only has to travel 1 to 2 inches into the urethra to get to the bladder versus 6 to 8 inches on a male. So that's just a little tidbit of information there. The functions of the urinary system. Filtration being the most important thing. Again, we talked about it filters the blood, removes the waste, and creates urine, which is the waste. Waste storage and excretion, storing in the bladder, and then eliminating that waste from the body through urination. Also, hormone production. This system produces hormones like, and specifically, erythropoietin for red blood cell production. Erythropoietin, or I'm sorry, as the blood moves through the kidneys, there are special cells in the kidneys that can detect low oxygen levels in the blood. And when that happens, erythropoietin travels to the bone marrow and stimulates the bone marrow to make more red blood cells. And then, of course, we need our vitamin D that is synthesized through the skin to assist with calcium absorption. So, this is just another look at how homeostasis works, because our skin, our integumentary system, synthesizes that vitamin D for calcium absorption for good bone growth. And in our bones, we have our bone marrow, which makes our red blood cells that we need for oxygen to travel to the cells in our body. And if that is low, then the kidneys will make erythropoietin. I'm sorry, I'm probably pronouncing that terribly, to create more red blood cells that we need for the oxygen in our blood. So, again, fascinating how the body all works together. It also creates renin, which is another hormone that helps to regulate blood pressure, which is really important for homeostasis as well. So our kidneys are really, really important parts of our body. And again, this can go much more in depth, but I'm hitting the high points. We're covering the basics. Urine formation, again, the kidneys filter the blood and pull out the waste, and how it does that is through these 3 stages to form that urine. So the first stage is glomerular filtration. Blood is filtered in the glomerulus, creating filtrate, and that's where it pulls out what's needed and what's not. What is okay to discard? What is the waste part? Tubular reabsorption, the useful substances like glucose and ions are reabsorbed back into the bloodstream. And then tubular secretion, all those wastes that were pulled out originally, plus additional waste that are added, are what form the urine or the unwanted substances for removal from the body. All right, some common urinary system conditions. Again, there are so many, but we're going to hit the high points. We're going to just talk about a few of the most common. Urinary incontinence, often caused by weakened pelvic muscles or nerve damage. There are different types of incontinence. There's urge incontinence, so you feel the urge to go and you can't make it in time, and so you have incontinence. Stress incontinence, that's really from the weakened pelvic muscles, like, so you have urinary incontinence when you cough, sneeze, jump up and down, whatever that may be. And then sometimes there's mixed incontinence, which is a little bit of both. Urinary tract infections, or UTI. The most common cause of a UTI is E. coli. E. coli is a bacteria that normally lives in the colon, and it's supposed to be there, but it is not supposed to be in the urinary tract. And that happens frequently from wiping the wrong way, so wiping front to back and getting fecal matter into the urinary tract. So that E. coli gets in there and it causes dysuria, which is painful urination, sometimes hematuria if it gets all the way up into the bladder or even up to the kidneys, causing pyelonephritis. So hematuria is blood in the urine, urgency, things like that. Because it is in bacteria, it can be treated with antibiotics. Renal calculi or kidney stones. mineral formations that cause a lot of pain because they kind of stop up the ureters, depending on where they are, but they can cause a lot of pain. Lithotripsy is one way to treat that, and that is using shock waves essentially to break up the stone so that they can be eliminated. Acute renal failure or kidney failure is the loss of kidney function suddenly. Typically, it is when it's acute, it means it happened all of a sudden, but it is treatable. So they treat the underlying cause, and that's usually how it's fixed. Chronic renal failure is a progressive condition, happens over time. To where there's a loss of kidney function that can't be restored. So there can be treatments like medications or dietary changes. If it's severe enough, then it's going to lead to dialysis, which we'll talk a little bit more about in the next slide. Pyelonephritis is a UTI as well, but it's in the kidneys. So if you see urethritis, that is a UTI in the urethra, cystitis in the bladder, ureteritis in the ureters, and pyelonephritis in the kidneys. It can be really serious if that bacteria gets all the way into the kidneys. It's going to require some strong antibiotics and sometimes hospitalization for that. For chronic kidney failure, dialysis is often the treatment. There are two forms of dialysis that you should be familiar with. There's hemodialysis. So remember, our kidneys are filtering the blood for us. It's pulling out the waste and keeping the good stuff. Well, when you have kidney failure, they're not doing that. They're not working to do that. And so one of the things that can treat that is hemodialysis, where the blood is filtered through an external machine instead of the kidneys. So these patients have a dialysis shunt that is surgically implanted into typically their arm. So it's vascular access there. It's fistula graft, catheter. There are lots of different terms for that. Typically, it's about 3 times a week that they need to go, and it is for multiple hours. And so the blood enters the machine, is filtered, and comes back into the body. Another option is peritoneal dialysis that uses the abdominal lining as a natural filter. It allows for more independence because it can be done at home. However, it has to be done every night and typically overnight to like 12 hours. And depending on the severity of the kidney failure and what their home life is like, and just a lot of factors, depends on which of these treatments the patient may have. Moving on to the reproductive system. The male and female reproductive system work together to achieve fertilization and produce offspring. Understanding how each of these works separately is really important, especially depending on where you go to work as a medical assistant. If you go to work in a OBGYN clinic or a women's health clinic, you're really going to want to be familiar with these things. All right, so we're going to talk about the female reproductive system first. We're going to talk about the primary structures, the anatomy, and then some of the physiology related to that. So with the anatomy of the female reproductive system, we have the external structures, often called the vulva. So that's the labia, labia majora, all of those external structures that can be seen from the outside. Which is typically if they come in for an exam and they're looking, that's the first thing they visualize to make sure all of that looks normal. And then there is the internal structures that a speculum is needed to visualize. And so that is the cervix, the vagina, and then the cervix. And then you can't really see the uterus from there, but further in there is also the uterus. And then the uterus has 3 layers. The endometrium, the inner lining of the uterus. We're going to talk about a little bit more in the next slide. And then the myometrium, which is the muscular layer of the uterus, which is really important for childbirth because it contracts to give birth to a child. And then the perimetrium, which is the outer layer of the uterus. All right, so let's talk about some of the physiology related to the female reproductive system. So the primary purpose is reproduction. So there are menstrual cycles. So the menstrual cycle and what we call the ovarian cycle tend to happen at the same time, so simultaneously. I'm gonna try to explain this separately and put them together if I can. So your menstrual cycle, the average cycle is about 28 days. You do need to know that for testing purposes. So average cycle. And because that's an average, that does mean that some women may have a cycle of 21 days and some may have a cycle of 35 days or whatever, but the average is about 28 days. So in that cycle, the first phase is the follicular phase, days 1 through 14, where the hormone follicle stimulating hormone, or FSH, stimulates follicle development in the ovaries, leading to estrogen production. So while that is happening in the ovaries, the follicle is forming thanks to FSH. The lining of the uterus is also getting thicker through that. The ovulatory phase around day 14, most people, if they have a menstrual cycle that's 28 days, ovulate around day 14. The hormone luteinizing hormone will trigger that ovulation or release of an egg. And then the luteal phase, days 15 through 28, a corpus luteum forms, producing progesterone to prepare the uterus for pregnancy. And so that's a cyst that forms on the ovaries. Yes, every month, if you have a period every month, you will have a cyst on your ovaries. That is normal. People get very concerned about cysts on their ovaries, but it's supposed to be there. What you worry about is if it's larger than it's supposed to be or it's there when it's not supposed to be, then that becomes an issue. But for most women, it's supposed to be there. If no pregnancy occurs, then that corpus luteum will degenerate, or it's supposed to, which then leads to menstruation. So that's when the lining of the uterus that has been getting thick, preparing for implantation, if it does not have implantation or no pregnancy occurs, then it will shed off, and that is your menstruation, meaning when you bleed. Fertilization occurs in the fallopian tube. You also need to know that. That will be a test question. So when intercourse happens, depending on what time of the month, if it's after ovulation and an egg has popped out from the ovary and is now entering the fallopian tube, if sperm enters the fallopian tube at the same time, it can then be fertilized, and then as it travels down, it will end up in the uterus with that thickened lining and will implant itself into the lining of the uterus or the endometrium, beginning a pregnancy. On this right-hand side are the key hormones that you need to be familiar with. I sort of just went through those, but you do need to especially be familiar with FSH, follicle stimulating hormone, and luteinizing hormone. And then also HCG, which is the hormone that's produced by the placenta early in pregnancy or throughout the pregnancy. And so when we start talking about pregnancy testing, that is the hormone we'll be looking for, is HCG. Here's another slide on the menstrual cycle, talking about FSH, the follicular phase, ovulation, when that occurs, the luteal phase, and then menstruation that happens. So it's just another breakdown. And that's a good little picture of the ovary, of what's happening there when the ovarian cycle is happening. Okay, some common female reproductive conditions Candidiasis, which is a yeast infection. It's caused by the fungus Candida albicans. Um, Very frequently, females will have a yeast infection because of the use of antibiotics. It could be hormonal changes. There are several causes. And because it is a fungus, we treat that with antifungal medications like fluconazole or miconazole. Genital herpes is caused by the herpes simplex virus. Type 1 is typically the one that we think of as like cold sores. And type 2 is typically genital herpes, but you can have type 1 on the genitals as well. It is transmitted through sexual activity. And just because you have one outbreak does not mean that you'll have another one. So, with this virus, you may have been exposed to it, 2 years ago and didn't have an outbreak, but then one day your body is, maybe you're sick and you're immunocompromised and that virus decides to activate. You may have an outbreak of genital herpes. Some people have outbreaks once a month. Some people have one in their life and never have another one. You just don't know. It depends on how your body reacts to the virus. There is no cure for this. Once you have it, you have it. But for those people who have frequent outbreaks, there are antiviral medications like acyclovir, valcyclovir, or Valtrex that can be taken to prevent the reoccurrence. Ectopic pregnancy. That's implantation of the fertilized egg outside of the uterus. Again, we talked about how it should be implanted in the lining or the endometrium of the uterus. That is where implantation should occur after fertilization in the fallopian tube. We do not want the egg to be implanted into the fallopian tube. That is dangerous. And if that happens, it's often a surgical emergency. And so, because your fallopian tube cannot handle an entire pregnancy, so it either is a laparoscopy to remove that, potentially remove the tube. There is medication like methotrexate that can be taken, again, if it's caught early. It just depends on the situation, really. Endometriosis is when endometrial tissue, so in the endometrium is the lining of the uterus, right, that sheds off when you have a menstrual period. It's when that tissue ends up somewhere else, not inside the lining of the uterus. So it may be on the ovaries, it can be on the bladder, it can be on the fallopian tubes, towards the rectum, just depending on where it is. So every month you still have those hormones. And so that endometrial tissue, let's just say it's on the bladder, it still grows and gets really thick. Well, when there's not a pregnancy, it also still sheds off and starts to bleed. And for your normal endometrium that is in the lining of the uterus, that blood comes out of the vagina, not an issue. But if it's on the bladder, it has nowhere else to go but in the abdomen, and that causes a lot of pain if it's somewhere it's not supposed to be. And so a lot of women with endometriosis have a lot of pain, and sometimes you can even figure out where it may be based off where their pain is. Treatments could be pain management, hormonal therapy, and even surgery. The only way to diagnose endometriosis is through a laparoscopy or a surgery to actually visualize the endometriosis. So there are a lot of women with these symptoms like pelvic pain and pain with periods and things like that that are common for endometriosis, but you can't diagnose it unless you have the laparoscopy or the surgery. And I say you, I mean the provider, obviously. Pelvic inflammatory disease, or PID, is often caused by STIs like chlamydia and gonorrhea, typically that are untreated. So if they have been left untreated for a long time, it can actually lead to infertility and can be really dangerous. PCOS, polycystic ovarian syndrome or ovary syndrome, hormonal disorder causing enlarged ovaries and small cysts. So polycystic meaning there's more cysts than they should be, or they're bigger than they should be. It is often associated with irregular cycles, excess androgen levels, which causes hirsutism, which is facial hair growth, um, insulin resistance, weight gain, things like that. So there are some different treatments for that. Again, it's really individualized on how they do that. And then cervical cancer, which is primarily caused by the human papillomavirus or HPV, which is a sexually transmitted infection. Um, and it is really common. I actually have a slide later on that. But depending on the stage, if it's precancerous cells, they may just follow up with it. They may do cryo, where they freeze the cervix. They may do a LEEP, which is a loop electrosurgical excision procedure, where they use an electrical cautery to remove those areas. If it is to the point of actual cervical cancer, then a hysterectomy is likely going to be the solution, with potentially radiation and chemo, depending on the severity and what's going on with that. Um, Cervical cancer screenings are pap smears, and they should be done if over 21 every 3 years, unless you at any point have an abnormal. If you have an abnormal, they're done more frequently. But the only screening for cervical cancer is a pap smear. Okay, the male reproductive system. Moving on, you have your primary structures, the testes that produce testosterone, which is important for sperm production, the scrotum, the sac containing, the penis, which is both used in the reproductive and urinary system, um, and the epididymis, which stores the sperm. Also, the vas deferens, seminal vesicles, prostate gland, which we'll talk a little more about. So, all of these parts are important for the male reproductive system. Some common male reproductive conditions: inguinal hernia, cryptorchidism, which is undescended testes. Uh, Typically, they don't worry about that in babies until about, I don't want to say the wrong thing, but I think it's 18 months. Um, if it's a baby that's testicle is not descended, I think surgical intervention after 18 months. Don't quote me on that though. Testicular torsion, which is a surgical emergency, and that's when the testicle is twisted and cuts off circulation. That is dangerous and requires a surgical emergency. And you will know if somebody has testicular torsion, because it is extremely painful. Benign prostatic hyperplasia, or BPH, is an enlarged prostate gland. In the male, the prostate gland is around the urethra. And so you can often, like one of the diagnostic factors is that they're unable to eliminate urine appropriately because of the urethra being kind of closed off. So they'll have dribbling or unable to empty their bladder completely. Some infections, epididymitis, prostatitis, and then testicular cancer, of course, are some problems. OBGYN care, your role as a medical assistant, patient preparation, clearly explaining the procedures, especially if it's their first time coming for any type of OBGYN exam. You want to make sure that they completely understand what's going to happen, ensuring their comfort, assisting with the procedure. A lot of these require a chaperone, so a medical assistant will have to likely stay. You could also hand instruments, set up equipment, collect specimens, patient education, which is really important for these types of procedures. Some more terms that you need to be familiar with. Gynecological terms and some of the procedures as well. Some common terms: amenorrhea, absence of menstruation. I'm sorry, I am having so much trouble pronouncing words today. Dysmenorrhea, which is painful. Menorrhagia, metrorrhagia, dysplasia, which is dysplasia is abnormal cell growth, which we typically refer to as our pre-cancer in the pap smear or cervical cancer screenings. Some procedures, colposcopy. So after an abnormal pap smear, the provider will typically order a colposcopy because a pap smear is a screening test, whereas a colposcopy is more of a diagnostic test. So they will look at the cervix. They'll insert a speculum, look at the cervix with a microscope, and then remove some of the tissue to be sent off to pathology. And if that one is indeed abnormal, then they will either do a cryosurgery, which is freezing of the tissue, or the LEAP procedure, again, depending on what the pathology results are. STIs or STDs, we used to say disease, but now it's sexually transmitted infections. Trichomoniasis or trichomonas, which is caused by a protozoan infection. It's often asymptomatic in men, but can be symptomatic in women. Typically, there is a greenish discharge and a foul odor from that. And those typically, if that is suspected, a wet prep is done. So it's a slide with some saline, and the provider takes a swab of the discharge and then puts it on the slide and looks at it under the microscope. And if you see that, those little protozoa, they have flagella and so little tails, and they're very happy to be there. The patient is not happy, but they're happy. They're just moving and wiggling, and it's very interesting to see. My students who go to the women's health clinics often see these. Chlamydia and gonorrhea, they tend to go hand in hand. They are bacterial infections, so they are treated with antibiotics, often injectable antibiotics like Rocephin, given in the office. Some of these can be asymptomatic as well, but if they do have symptoms, it can be discharge, pain, things like that. Genital herpes, which we've kind of already talked about, they present as sores, and blisters that can be extremely painful. Syphilis, NHA likes to ask about the bacteria that causes syphilis, which is Treponema pallidum. So be familiar with the name of that bacteria. And it causes canker sores, and can be very, very, very serious if left untreated. HPV, which is the virus, the human papilloma virus that can cause genital warts as well as other cancers and cervical cancer, which we'll talk about in the next slide. And then HIV and AIDS. HIV is an STI that can eventually turn into AIDS if left untreated. However, HIV now is extremely manageable with antiretroviral therapy. So let's talk a little bit more about HPV. So the human papillomavirus is sexually transmitted or is transmitted through sexual contact. Nearly 80% of sexually active people in the world will get HPV at some point. It is the most common STI in the United States. It causes 90% of cervical cancers, and is also linked to oropharyngeal, anal, penile, vulvar, and vaginal cancers. It causes, I think, about 70% of oropharyngeal cancers. That's cancers of the mouth, neck, and throat. There are 13 million new infections every year and 45,000 annually. Cancers annually. Sorry. There is a vaccine for HPV that prevents the high risk strain. So there are hundreds of strains of HPV. Certain ones cause the warts. Certain ones cause cancers. The top two that cause cervical cancer are HPV strains 16 and 18, and that is what the HPV vaccine prevents against. And there is a decline in the infection rates related to the vaccine. I would say more importantly, or just as important, I would say, as vaccination will be, because this is an STI and it is so common, and oftentimes has no symptoms. Um, STD prevention discussions, patient education, safe sex practices. I find that education is just as important as vaccination. It is most of my history is working in women's health, and it is very surprising the amount of women who have no idea about their own anatomy, um, much less safe practices, that they just did not get any of this. They're just unfamiliar with anything related to the female reproductive system, honestly. So I find that education is really important and extremely lacking. Okay, so some of the components of a gynecological exam. When a patient comes in for an OBGYN exam, the provider will typically do an external assessment of the external genitalia and the vulvar area, looking for any lesions or signs of infection. Um, they will also do an internal exam, a speculum exam. A speculum is used to visualize the walls of the vagina and the cervix. Um, Depending on the age of the patient, or if they need one, they may also collect for a pap smear or a pap test, to screen for cervical cancer and HPV. And so while this speculum is inserted, they can use, depending on their preference, a cyto brush, a paddle, a broom. It just depends on what they have, and what their preference is. And they will take samples of the cervix, so some cervical cells, put that in the container and send that off for pathology. A bimanual exam is used to palpate the uterus, ovaries, and fallopian tubes. So typically they place one hand over the abdomen and fingers into the vagina to assess. That is the only way to assess the ovaries. There is no screening for ovarian cancer. So it is really important that this part is done in the exam so that the provider can feel the ovaries and make sure that they do feel normal. Um, Depending on symptoms, they may also do a rectal vaginal exam. That is not as common, but could be done. Contraceptive methods, there are multiple. So there are hormonal methods, which are probably the most common. That's things like pills, which have typically combination hormones like estrogen and progesterone, patches, rings. The rings have to be inserted. Typically, the ring is there for 3 weeks, it's taken out, have a period for a week, and you put a new one in. Patches, same thing. They wear that for 3 weeks, they take it off, they have a period, they put a new one on. Injections like Depo-Provera, that's typically every 3 months. They get an injection, it's good for 3 months, they come back in. Implants like the Nexplanon, or I think it's Nexplanon, is inserted, and it is good for 3 years, I believe. It's inserted into the arm. There are barrier methods. While all of these methods help to prevent pregnancy, the barrier methods are the only one, specifically condoms, that help to prevent STDs. So those are really important on top of preventing pregnancy, to be used. So that's condoms, diaphragms, cervical caps, even some that have spermicides. Um, is again, those are really important for STD use, the condoms. IUDs, which are intrauterine devices, they can be non-hormonal, which is the copper IUD, the Paragard, which lasts about 10 years, or hormonal like the Mirena, which is 5 years. Is it 8 years now? New studies are showing that it can be left in longer. So those are inserted into the uterus. And then there are natural family planning methods, which are being aware of when you ovulate. That takes a lot of, you have to be really good at that. That is not for people who are not going to stay on top of it. So, again, which method is chosen is really dependent on the person, it's very individualized. Pregnancy basics. Typically, a pregnancy lasts about 40 weeks from their last menstrual period. When a patient comes in for any type of OBGYN exam, you always ask them when their last menstrual period was, and you need to be specific. You need to ask them the first day of their last menstrual period, because if you don't say the first day, sometimes they'll give you the last day, and that's not what we're looking for. We're looking for the first day, especially if they come in for a pregnancy visit. So the first, you have trimesters. Your first trimester is weeks 1 through 12. Second starts at 13 weeks and goes to 26. And then the third trimester starts at 27 and then all the way to 40 or delivery. The OB visit schedule starts off monthly, and then around 28 weeks, they start coming bi-weekly, every 2 weeks. And then from 36 weeks until delivery, they're there every week. And there are common tests that we do: blood work, ultrasounds, glucose screening at the end of pregnancy, and then group B strep as well. Some pregnancy complications that are common. Well, I don't want to say common, that we would be concerned about. Gestational diabetes. At the end of a pregnancy, every woman will get a glucose screen where they will drink a 50-gram glucola drink, and then have their blood tested an hour later. If that was abnormal, then they would do a 3-hour glucola drink. And so they would drink 100 grams of glucola, and they would have their blood work done at 1 hour, 2 hours, and 3 hours. If 2 of those are abnormal, then they would be diagnosed with gestational diabetes. And that can be dangerous because the baby will likely need treatment. They also cause gestational diabetes untreated can cause really big newborns, really big babies. And I can't think of the word right now. Preeclampsia, something we look at after 20 weeks, typically towards the end of pregnancy. It is identified by high blood pressure, protein in the urine, a lot of times swelling in the feet, and it can be very serious. If left untreated, it can turn into eclampsia, which is a seizure disorder, which can be very, very dangerous. Placenta previa, where the placenta is covering the cervical opening, that can be dangerous. It can cause a lot of bleeding with delivery. Placental abruption, the same thing, when the placenta separates from the uterine wall. Too early premature rupture of membranes is when their water breaks before it should, or they don't go in within enough time. It can really increase the risk of infection. Stages of labor. For childbirth, stage 1 is when the cervix starts to dilate. This is the longest stage because it takes a while to dilate fully to 10 centimeters. So that's once the cervix starts to dilate. Stage 2 is expulsion, or when the baby is born or delivered. And then stage 3, which is when the placenta is delivered, typically about 5 to 30 minutes after the baby. And then it talks about some medical assistant care. Okay, so moving on to the endocrine system. I tried really hard to be short with the OBGYN section, but that's where most of my experience is, so I probably added more than I needed to. Okay, so endocrine system. I will also try to keep this short, but this is my favorite body system, so I'm going to try to, again, hit the high points. This will probably be the longest lecture, and I apologize. So the endocrine system is a system of glands that release hormone into the bloodstream that help to regulate body processes, different ones. It collaborates with the nervous system to maintain homeostasis. It influences growth, metabolism, reproduction, stress responses, fluid balance. Really does support overall well-being. Some of the things that we've just talked about only happen because of the endocrine system. All right, so some of the structure or anatomy of the endocrine system: the hypothalamus, which is in the brain, links your nervous system to your endocrine system by stimulating the release of hormones. The pituitary gland, which we call the master gland because it controls a lot of other glands. It produces 8 hormones total, which are vital for the function of some of these other glands producing hormones. The thyroid, which regulates metabolism, parathyroid, which regulates calcium levels, your adrenal glands, which produce stress hormones, like have you ever heard of adrenaline, um, and regulates electrolytes, your pancreas, which produces blood glucose through insulin and glucagon, or it regulates it. The gonads, which are your reproductive anatomy. So in a male, the testes produce testosterone, and in the female, the ovaries produce estrogen and progesterone. And then you also have the pineal gland in the brain that produces melatonin, which is important for sleep wake cycles. And then the thymus in the neck, which produces thymocytes for immune function. That is where T cells are stored. All right, so let's talk about the master gland or the pituitary gland. The anterior portion of the pituitary gland secretes these hormones: prolactin, which stimulates milk production in the mammary glands following childbirth, growth hormone, which promotes the growth of body tissue and bones, the adrenocorticotropic hormone, or ACTH, which stimulates the adrenal cortex to produce cortisol and other hormones, thyroid stimulating hormone, or TSH, which stimulates the thyroid gland to produce the thyroid hormones, T3 and T4, luteinizing hormone, which we just talked about in the reproductive system, which triggers ovulation in females. It also in males stimulates testosterone production. Uh, follicle stimulating hormone, or FSH, in females promotes the follicle development in the ovaries, and in males stimulates sperm production in the testes. And then melanocyte stimulating hormone, or MSH, influences skin pigmentation. Posterior hormones. So I always tell my students, how do you remember which ones are anterior and which ones are posterior? If you know the two that are posterior, then the rest are anterior. So for the posterior pituitary hormones are just two. One is oxytocin, which stimulates uterine contractions during childbirth and milk injection during breastfeeding. Don't confuse oxytocin and prolactin. Prolactin stimulates milk production. So it's producing the milk, but it stays there until oxytocin, which is when it ejects during breastfeeding after the baby is born. Antidiuretic hormone, or vasopressin, regulates water balance by promoting water reabsorption in the kidneys, decreasing urine output. So if you are dehydrated and your body needs water, it's going to start reabsorbing water instead of letting some of that water go out in urine. Other important hormones: your thyroid secretes T3 and T4, which regulate metabolism, as well as calcitonin, which lowers blood calcium levels and increases it in the bone. So it takes calcium out of the blood and puts it into the bone. Adrenal hormones. Actually, let me go back. On your thyroid, you have the 4 little spots on the thyroid gland, a parathyroid, which secretes parathyroid hormone, which raises calcium levels in the blood from the bone. So those can be a little confusing. In the thyroid, the calcitonin lowers blood calcium levels, whereas the parathyroid hormone increases blood calcium levels. Adrenal hormones. The adrenal glands sit on top of the kidneys like little hats, and they secrete epinephrine and norepinephrine. That's your adrenaline, or your fight or flight response. Aldosterone, which regulates sodium and potassium levels, and then cortisol, which is responsible for your stress response and metabolism regulation. Pancreas secretes insulin, which lowers blood glucose, and glucagon, which raises blood glucose. And then we've already kind of talked about the testosterone, estrogen, and progesterone. Some common endocrine conditions: Addison's and Cushing's disease. Addison's is an underproduction of cortisol from the adrenal glands, whereas Cushing's is an overproduction of cortisol. And they have very distinct looks. Type 1 diabetes and type 2 diabetes. Type 1 diabetes is autoimmune. It leads to the absolute ineffective insulin production, meaning that in order to live, these patients have to have insulin therapy via injections. They cannot take like a diabetes pill that does not work. Their pancreas is not producing insulin to lower their blood glucose level, so they have to have insulin every day by injection. Symptoms of diabetes are polyuria, which is frequent urination, polydipsia, which is increased thirst, polyphagia, which is increased hunger. Type 2 diabetes is insulin resistance, which is often caused by diet, lack of exercise. Um, it has a lot of the same symptoms. It can be treated by changing lifestyle, like diet and exercise, oral medications, and sometimes, if severe, insulin therapy. Thyroid disorder, hyperthyroid, which is excessive thyroid production. And again, remember this is for metabolism. So it's like they have increased metabolism, so they have weight loss. And then hypothyroidism, which is insufficient, which would cause weight gain. And they would need hormone replacement like levothyroxine or Synthroid. Um, Graves' disease is autoimmune version of hyperthyroidism, which causes exophthalmos, which is bulging eyes, goiters on the neck, and that can require oftentimes surgery or radioactive iodine. Speaking of iodine, I would like to say, I don't know if I have it mentioned anywhere else, but your thyroid needs iodine to function properly, which is why a lot of salt is iodized salt. Okay, so the nervous system. The nervous system is the body's command center. It's responsible for transporting information. It is how our body knows to function and respond to internal and external stimulus. There are two divisions of the nervous system. You have your central nervous system, which is made up of the brain and spinal cord. Your brain handles all of your conscious thought, your memory, emotions, and voluntary movements. Your spinal cord communicates between the brain and the rest of the body. Your peripheral nervous system connects the central nervous system to the body. It includes the somatic nervous system, which is for voluntary movements, and includes the autonomic nervous system for automatic functions like your heart rate or digestion. The autonomic nervous system can also be broken down into sympathetic and parasympathetic. Sympathetic is fight or flight, whereas your parasympathetic is rest and digest. So let's just say your autonomic nervous system, all of digestion has happened normally, your heart rate has happened normally. But your sympathetic division, so if you see something scary, so let's just say you're terrified of spiders, and you see a spider, your body goes into fight or flight. So whether or not you're going to fight it or you're going to run. So during that time, your body automatically knows to increase blood flow to the heart, to the respiratory system, because if you have to run, your heart's beating faster, your respiratory system you're breathing faster, but it slows down to the digestive system. Your body is not worried about digesting your food if you need to be running. Whereas once that's over, your body can go into rest and digest, where it starts to like recover from that. Your heart rate lowers, your respiratory rate lowers, your digestion starts again. The fundamental unit of the nervous system is the neuron or the nerve cell, which transmits electrical and chemical signals throughout the body. That's how we have communication in response to stimuli. So here's another breakdown of your central nervous system. Over here is your brain, which controls all your bodily functions, and your spinal cord. And then your peripheral nervous system, or your peripheral nerves that branch off from the spinal nerves. The neuron The basic unit of the nervous system has some parts, has the cell body or the soma, which contains the nucleus and organelles, dendrites, which are the branch like extensions that receive the signals from the neuron. That's how things are communicated. The axon, which is the long fiber that transmits signals away from the cell body. It serves as the main information highway. And then the myelin sheath, which is the insulating layer, which speeds up signal transmission in the need for crucial or rapid communication. Central and peripheral nervous system again, brain and spinal cord, and your nerves outside, which we've kind of already talked about. Some common conditions of the nervous system: Alzheimer's disease, progressive brain disorder. There are medications. There's no cure, but there is medications to help manage symptoms and supportive care. Cerebral concussion, which is caused by TBI or traumatic brain injury from impact. Symptom management is the big thing here. Sciatica, for compression of the sciatic nerve. A TIA, which is a transient ischemic attack. That's what people like to call like a mini stroke. But it is temporary blockage to the brain blood flow, which oftentimes is worrisome because it can lead to a stroke or a cerebrovascular accident or CVA. That is where there is reduced blood flow to the brain based off of a clot in the brain or a ruptured blood vessel in the brain, which causes a hemorrhage in the brain. Treatment is early intervention, so being able to recognize a CVA, and we use the FAST acronym, which is facial drooping, arm weakness, slurred speech, time to call 911. And then seizures are the result of abnormal brain activity, sometimes resulting in convulsions, and treated with anticonvulsant medications. Again, that's very individualized as well. The sensory system, as part of your nervous system, they work together, connects us to the world through our ears and our eyes, taste, feel. All of those are part of the sensory system. So the eye, the anatomy of the eye and the physiology. So the eye is a hollow fluid-filled sphere that is comprised of 3 layers. You have the fibrous layer, which is the protective or the outside that you can see. So the sclera, or the white of the eye, and the cornea. And you can actually see the pupil through the cornea. The vascular layer, or the choroid, which contains a lot of the blood vessels. It's where the ciliary body is, and the iris, I'm sorry, that controls light entry. Couldn't think of the word. And then the neural layer, which is the retina. It has the photoreceptors, where the rods and cones, they capture light and convert it to electrical signals. How that works is light travels through the cornea, then through the pupil, then the lens, and then to the retina. And it is then converted to electrical signals that are sent to the brain via the optic nerve that gives you a picture and allows for vision, which is also very fascinating. And that is a very basic summary of how that works. Anatomy and physiology of the ear. You have the external ear, which consists of the auricle or pinna, which is the part that you can touch on the outside of the cartilage. You have the auditory canal that goes in to the ear, and then the tympanic membrane, or the eardrum. The middle ear has the 3 smallest bones of your body, called the ossicles. They are the malleus, incus, and stapes. And they are connected to the eardrum or tympanic membrane, and use vibrations to make sound. I'll explain that in a minute. And then the inner ear houses the cochlea, the vestibule, and semicircle canals. which are used for balance over hearing. So, how that works is the sound waves enter the auditory canal, they vibrate the tympanic membrane, which then vibrates the ossicles, the malleus, incus, and stapes. They amplify the vibrations into the cochlea, and the cochlea converts those vibrations into neural signals, which are sent to the brain via the auditory nerve. So again, very fascinating how those vibrations can turn into the sounds that you hear. Your role as a medical assistant in eye and ear health, assessment, gathering data related to any vision or hearing changes, or things like dizziness and balance, because that is done by the inner ear. So if they have something like vertigo, which is imbalance or issues with balance, or tinnitus, which is ringing in their ear. So being able to assess for those things. Patient education on proper ear and eye hygiene, avoiding irritants, eyewear, and then clinical support, which we're going to talk about some skills, some clinical skills related to the sensory system. Some of those skills are diagnostic proficiency. So using a Snellen chart. A Snellen chart is the eye chart or vision chart. For visual testing, the patient, if they're an adult, should be standing 20 feet away from the chart. They cover one eye at a time, and then the result is done into fractions. So depending on which line they read, whether or not their vision is 20/20 or 20/40. For children, you may use a different type of chart with pictures versus letters, and they only stand 10 feet away from the chart. The Jaeger chart is used for near vision testing. So they hold it about 16 inches, I believe, away from the face to check for near vision. Anytime you are to do anything in the ear, whether you're doing ear drops, you're doing a temperature or a tympanic temperature in the ear, or if you're looking in the ear with an otoscope. If it is an adult, you will pull the ear up and back to open the auditory canal. If it is a child younger than 3 or 3 or younger, then you would pull the auricle or pinna down and back so that you can visualize the auditory canal. Therapeutic procedures that may be so eye drops or eye ointment. If you are instilling eye ointment or educating the patient on how to do that, we always make sure we tell them not to touch the tip of the bottle to their eye, because it should stay sterile. So for an ointment, we would have them put it on the conjunctiva or the lower eyelid from the inner canthus, so the inner corner to the outer canthus. For eye drops, you would hold the conjunctiva down, have the patient look up and drop it, again, not touching the dropper to the eye. For eye irrigation, you'll have the patient positioned with the affected eye lower than the unaffected eye, because we don't want whatever's in it to also run into the unaffected eye. And you would use sterile saline to clean or irrigate from the inner canthus to the outer. For ear irrigation, or for ear drops, again, if you're putting in ear drops, if it's an adult, you pull the ear up and back to open the canal and put the ear drops in. If it's ear irrigation, you're irrigating the ear. A lot of times that is used to remove cerumen or earwax buildup. You make sure that you use body temperature water. Water that is too cold or too hot can cause dizziness and other problems. So it's got to be body temperature. And you're going to gently insert it into the ear to remove whatever you're irrigating. Okay, so let's move on to mental health. Mental health refers to a person's cognitive ability, behavior, and emotions, and it is vital to overall wellness. Some things that can affect mental health are biological factors like genetics, and brain imbalances. Some things, it's environmental influences like trauma, stress. And there are multiple treatments for this. Your job as a medical assistant is to approach any patient with a mental health condition, diagnosed or suspected, with empathy and professionalism, making sure that you're using your active listening and communication skills. And then some of the treatment approaches. So you, as a medical assistant, may be responsible to referring to some things like a psychiatrist or a psychologist for psychotherapy or talk therapy. Some things like lifestyle modifications, you may be responsible for educating on these. Some common mental health conditions include depression, which is linked to chemical imbalances. It often causes, most people just think sadness, but really they're not interested in doing anything that used to make them happy or bring them joy. They like to lay in the bed and sleep. They're tired all the time, that kind of thing. And that can be treated with talk therapy, psychotherapy, antidepressants. Anxiety can be caused by stress, trauma, or just a genetic predisposition. That can be done with cognitive behavioral therapy and anxiety medications. ADHD, caused by genetics, neurological differences, can be treated with behavioral therapy and medications as well. PTSD, post traumatic stress disorder, caused by an exposure to a traumatic event. Again, therapy as well as medications for that. And then some of the mental health things that you need to understand. We've already talked about Maslow's, but I'll go over them real quick. This is understanding the hierarchy that helps recognize the patient's fundamental needs. So that first layer is the physiological needs, like food and water. Have to have that before they can move on to safety, which is like shelter, security, uh, good health care. Love and belonging, the importance of friendships, emotional connections, esteem for respect, recognition, and then self actualization, which is achieving their personal highest potential. Stages of grief. This is new. Elizabeth Kubler-Ross came up with these stages of grief. And this, when we're talking about grief, that does not necessarily mean there's a death. It can mean a death, but it can be a grief of any type of emotional journey. So it could be something like a new diagnosis. So they've got a new diagnosis of diabetes and they're grieving that. So the stages typically go DABDA. That's what we always say, DABDA. Denial, anger, bargaining, depression, acceptance. So denial is typically the initial response, shock, disbelief, avoiding it. Anger, which is frustration, blame, bargaining. That's typically those what if thoughts. What if I did this, or what if I had done that? Trying to negotiate. Depression, profound sadness, hopelessness. And then acceptance, coming to terms and finding peace with whatever this grief process is. These stages do not always go in this order. Some people skip some altogether. Some people move back and forth. Again, that's very individualized, but these are the stages of grief. Erickson's psychosocial development stages. We talk about this with pediatrics. This is important when you're communicating, especially with pediatrics. So this is the developmental stages that is the theory that Erickson came up with. Infancy, so like 0 to almost 2, is the trust versus mistrust, developing trust in caregivers and the world. If they do not, then they're going to have some issues already from infancy. Autonomy versus shame and doubt is typically toddlerhood, so like 2 to 3. They're developing independence. I like to think like that's like potty training, having that autonomy, versus shame and doubt, which is like if they're having accidents and things like that, which was why we don't want to shame children who have accidents. Initiative versus guilt is preschool, so typically 3 to 5. They're exploring and initiating activities. That's very much the I'll do it myself stage. And then 4 is industry versus inferiority. So that's school age children, the industry being school. That's about 5 to 12. That's the big deal in their life at that point is school, right? Adolescence, so 12 to 18, is identity versus role confusion, where they're developing their own personal identity, or they're confused about who they are. Um, Intimacy versus isolation, so that's young adulthood. So think typically 20s to 30s. They're forming intimate relationships. That does not have to mean like a spouse. It could be like, a best friend, things like that. But like having a person, finding your person versus isolation. Middle adulthood, 40 to 60-ish. Generativity versus stagnation, meaning am I contributing something to society, to future generations? What have I done? And then the last stage, or late adulthood, 65 plus, is ego integrity versus despair, like reflecting on, have I made my mark on this world versus regret. Some common defense mechanisms. This is important with your good communication skills, that you be aware of some common defense mechanisms that people may have. These are coping strategies. So things like denial, that's obviously the most common, refusing to accept that, like, I don't have a drinking problem. Repression, unconsciously repressing what happened so that they don't bring up the painful memories. Sublimation, channeling unacceptable impulses into productive activities. So the example they use is using anger in sports. So the anger, and because you can do that in sports, but that's not ideal. Projection, attributing your own feelings or to another, like claiming someone else is angry when really you're the one that's angry. Displacement, redirecting emotions to a safer target, slamming the door when they're upset. Also, that can be definitely blaming the medical assistant. They're displacing, you did something because they don't want to take responsibility themselves. Compensation, disassociation, regression, and suppression are some more that you can read through. The medical assistant's role in patient care in these body systems: empathetic communication. Patient education is really important for these body systems, for all of these. And then professional conduct, as always. So for the urinary system, we've talked about it filters blood, produces urine, maintains fluid balance. Key terms you need to know: the kidney, the ureter, the bladder, the nephron, which is the functional unit of the kidney. Common conditions: UTIs and kidney stones. And as a medical assistant, you're likely to handle urine collection and patient education on hydration and prevention of UTIs. The reproductive system produces hormones and sperm and eggs for reproduction. Key terms: ovaries and fallopian tubes for females, testes and prostate for males. Understanding conditions like PCOS and BPH. Assisting in exams and patient education on contraception and STIs are important for medical assistants. For the endocrine system, it regulates function through hormones like insulin. Common conditions include diabetes and thyroid disorders. Monitor blood glucose, assist with tests, educate patients on medication adherence are critical roles of the medical assistant. The nervous system coordinates body's activities and transmits body signals. Key components are the brain, spinal cord, neurons. Important conditions are like stroke and seizures. As a medical assistant, you may assist with neurological exams, ensure patient safety, and education. So for the exam, the CCMA exam, again, there are not a bunch of anatomy and physiology questions. I think there's, if I remember correctly, 8 on the whole exam. However, having an understanding of these different body systems helps you with that practical clinical scenario type questions that NHA will ask.